This is the chairwoman, ladies and gentlemen. Thank you to be there at the end of the day. We have a very long day today, and I will discuss some important questions. Many of you are working in an IVF center. I'm a surgeon, and for ovarian endometrioma, should we do surgery or IVF? There is a lot of debate on that topic with my friend Diana Somigliana, who is responsible of this slide. It's really a whole topic. Look, this is a slide of 2006. And there were a balance between surgery and expectant management. And this debate remained a very hot topic. In December last year, there was a fertile battle. Women with endometrioma-related fertility face a dilemma when choosing the appropriate therapy, surgery or IVF. And looking back to the literature, I was really astonished that in all countries of the world, in fact, surgery versus IVF for endometrioma is a really hot topic. Surgery of IVF, in the New Zealand and Australian Journal of Obstetrics and Gynecology, the simplicity of these questions believes its complexity. And the answer was when all of you have this hammer, everything looks like a nail. That was the debate. But in Australia, what is the debate now in Europe and the United States? There was published, you see, in December 2018, this fertile battle. And in fact, when you look, the pro-surgery, Bruce Lessay, Stéphane Gotz, and Olivier Donnez. And Bruce Lessay starts his paragraph telling that the elephant in the room is not the endometrioma, but 3 dots. And on the other way, for IVF, Somigliana, IVF should be the first approach. For ovarian endometriosis and infertility, you see that Charles Chapron came from surgery to IVF, and of course, Velasco is in favor of IVF. But we have to analyze carefully the risk. First, the risk of IVF prior to surgery. Progression of the disease, increased inflammation, difficult oocyte retrieval, risk of cycle cancellation, fluid contamination, endometrioma infection, undiagnosed occult malignancy, risk of rupture with subsequent chemical peritonitis, and pregnancy-related complications. It's all the risks described in the literature. But on the other way, there is risk of endometrioma surgery prior to IVF. In fact, it depends on surgeon skill. And probably the most important point, the cost, the possible surgical complication, the impact to ovarian reserve, and the risk of premature ovarian failure, incomplete surgery and recurrence, and may delay assisted reproductive technique. So that my question is, in a debate, where are we going? But let me go back to ovarian endometriosis and to the pathogenesis. Because too frequently, depending on the center, we send the patient to IVF or to surgery, and we don't think very well to the pathogenesis. And for us, the consequence is the metaplasia, and we know that the mesothelium is responsible for metaplastic changes. including the cancer. And the invagination of this mesothelium with subsequent metaplasia produced an endometrioma. And when we look very carefully to this picture, and if I make a close-up of this ovarian, which is obviously an ovarian containing endometrioma, you see at the close-up that 90% of the endometrioma is just chocolate fluid. But the problem is that the normal ovarian cortex is this very thin, very thin area with the follicle represented here, the antral follicle in white. And if you do a biopsy of the endometrioma, here, there's the endometrioma, is the residual ovarian cortex. And if you do a biopsy, you may see the chocolate fluid. The endometrial epithelium and stroma very thin. And then the fibrosis. The fibrosis, which is called by endoscopists the capsula. It's a big mistake. There is no capsula. Indeed, there is no plane of cleavage between the pseudocapsula, which is only fibrotic tissue, and the normal ovarian tissue with all the ovocyte. And imagine if you try to stretch this fibrotic area, the risk to remove together numerous ovocytes is very important. So then the question is, do we need to treat by surgery endometrioma before IVF, if IVF is indicated, or in any condition? Pay attention. I'm not speaking about recurrence of endometrioma after surgery. This primary endometrioma. And if you look at the literature, there is a lot of papers, and I will focus on the paper by the team of Hamdan and Düsselmann, published in the Human Reproduction Update, and they analyze, in a meta-analysis, 33 studies. And the conclusion were that women with endometrioma undergoing IVF fixing had similar reproductive outcome compared with women without the disease. But they mentioned that the cancellation rate is significantly higher. I was asked by Fertility and Sterility to make an editorial on that, and in fact, the data on the impact of endometriosis on IVF results are controversial. And in the study, analyzing in detail the meta-analysis by Hamdan and Düsselmann, they conclude that women with more severe endometriosis, stage 3 and 4, are poorer reproductive outcome. They also found a similar clinical pregnancy rate, labor rate, and miscarriage rate in women with and without endometrioma. But in fact, the separation, the classification between the two groups is very difficult. That is the reason why I say that it's controversial. Moreover, the cancellation rate is 3 times higher. And everybody will agree that there is a consensus for that. Fewer mature oocytes are retrieved, and it could have repercussions by reducing the number of embryo potentially available for frozen embryo transfer, and so have an influence on the cumulative live birth rate. So that is the quality of the oocyte. And it is only an hypothesis. Further investigation are required, but it could be that the oocyte presents some change, some anomaly like mitochondrial content, spin anomalies, dark central granulation, as zona pellucida pitae. But no clear evidence The only evidence is the number of empty ovocytes. Cochrane review. For the endometrioma and surgery, I don't believe in the Cochrane review. I noticed just that you mentioned why. Why? Simply because that was the conclusion of the Cochrane. Some evidence that excisional surgery for endometrioma give better result than drainage and ablation with regard to the recurrence of the endometrioma, recurrence of symptoms, and subsequent spontaneous pregnancy rate. I was really unhappy with that, because from that moment, all the gynecologists in the world, often endoscopists, start to do aggressive surgery, cystectomy, because even the Cochrane tell that it was better. But they include only 2 randomized studies, Beretta and Alborzi, with a very low number of patients, less than 100 per group, and moreover, in the control group with the ablation, the experience was completely different. I never understood where a conclusion was made with 2 randomized studies with a small number. Moreover, the post-op ovarian reserve in the 2 studies was not evaluated. Nevertheless, we know for a long time, I have no time to go into details of all the studies. Look, all the papers in good journal. Since 1996, a lot of papers describe that the follicular response to the ovarian reserve is decreased after cystectomy. And you see that even Münzi found in case of excised tissue follicular follicles. We do the same. You see a lot of paper really describing that cystectomy for endometrioma could be deleterious for the ovarian reserve. Just to keep in mind one of all these papers, the paper by Münzi. When you remove the capsula close to the ovarian gills, the ovarian tissue removed along the endometrioma wall mostly consisted of tissue which contained primordial, primary and secondary follicle in 69% of cases. In fact, there is no plane of cleavage. Just when you remove the capsula, you remove together normal ovarian tissue. That IVF surgery, do we have scientific arguments in favor of surgery? In fact, the ovarian reserve is already depleted in more or less 30% of the women with endometrioma even before surgery. And we are in this situation that even at the age of 20, the ovarian reserve in patients with endometrioma is already very low. And of course, it decreases with the time. And at the pathogenic point of view, the question is why? And we work in the lab on this specific problem. The first paper was an hypothesis. Endometrioma is a possible cause of reduced ovarian reserve in women with endometriosis. And the second paper, where we prove that in fact there is an enhanced follicular recruitment and atresia in cortex derived from ovaries with endometrioma. And in fact, we analyzed in a biopsy from normal ovary compared to the contralateral ovary with an endometrioma, the anomalies of the follicles and the atresia. And we could determine that the atretic follicles, this is the rate of atretic follicles, were significantly high in the cortex from ovaries with endometrioma when compared to the cortex now of ovaries without endometrioma. Why? Because the endometrioma is responsible of a local inflammation, structural destruction of surrounding normal cortex, with fibrosis and loss of cortex-specific stroma, provoke an enhanced recruitment and atresia, with a dysregulation of the folliculogenesis, with as a consequence growing follicles, but finally it provokes a burnout with a decrease of IMH. It's what we call the burnout effect, caused by the endometrioma itself. And very recently, Mulzi made a meta-analysis and systematic review of the anti-Mullerian hormone in women with ovarian endometrioma, and it was well proved that even before surgery, IMH is reduced. And some other speakers spoke already about the oxidative stress. We published a paper suggesting that the oxidative stress has a role, and a role also into the ovary to explain this inflammation, intra-ovarian inflammation. And even you see, there's a slide from Sumigliana. Even him acknowledged that the chocolate fluid may have a toxic effect on the normal ovarian cortex in the follicles. So that, okay, if endometrioma is a progressive disease, we have argument in favor of surgery, but which surgery? Not the classical one, because we know that the plane of cleavage doesn't exist. And in fact, the only pathological cells are the endometrial epithelium and stroma. In fact, if you evacuate the liquid, the chocolate fluid, and you ablate only this part with the abnormal cells, it should be good. There is no need to remove everywhere the pseudocapsula. So that we have proposed what we call the combined technique. We start with the excision, and when we are close to the hilus, we stop the excision. Because we are close to the hilus, and we know by the study of Mulzi that if we continue the excision, we will ablate, we will remove together the normal ovarian cortex. So that by surgery and by endoscopy, we remove more or less 80% of the cyst wall, and at the end, close to the hilus, we just ablate. And you see the final result, and we demonstrate by this technique, called the combined technique, excision and ablation, that in fact, the ovarian volume and the anti-follicle count were, after surgery, similar to those observed in women without endometriosis. Moreover, if the surgery is carried out for primary ovarian endometrioma, we observe that after surgery, more or less 50% of the women are pregnant after surgery. Then there is a plateau. It is the reason why, after 1 year, if the patient is not pregnant, we will send to IVF. And of course, all women who are not pregnant will be sent to IVF. Even in a recent paper published in Nature, a group of Italian and Robert was included in that paper. And beautiful cartoon, you see here, women with endometrioma, they are considered as stage 3 and 4. And in the algorithm, they clearly mention that if pain of large endometrioma is present, laparoscopy approach should be carried out. So that I'm not the only one to propose surgery for endometrioma. And it is the slide I would like to conclude with. In case of ovarian endometrioma, surgical approach first, yes, because ovarian endometrioma is a progressive and inflammatory disease which is by itself deleterious for the ovarian reserve. And the second argument is that surgery allows patients to be pregnant naturally in more than 50% of cases. Thank you very much for your attention. Just one slide, sorry. Even Garcia Velasco and Liliana, really the gynecologists in favor of IVF, proposed safety indication for resection, rapid growth, suspicious feature, pain, potential for rupture during pregnancy, inability to access follicle during IVF, and for me more than 3 centimeters is a safe indication. Sorry. Yes.